Hello and welcome to DAS Health's webinar, MIPS and CHIPS, Lunch and Learn for the Improvement Activity category. My name is Bridget Peterson and I am part of the Government Incentives team for DAS Health. Before we get started, I would like to take a moment to explain the process for today's presentation. First, I would like to mention that this webinar will be recorded. We'll send out a copy of the slides and recording within the next week. Next, for those of you who aren't familiar with DAS Health, I encourage you to visit our website, connect with us on LinkedIn, and subscribe to our YouTube channel, where you can access all of our historical webinars. I also want to mention the final upcoming session of our educational webinar series, MIPS and CHIPS, a Lunch and Learn series on each category of MIPS that we are presenting now until the end of June. I know we are already on our third session, but the final category we will be covering will be on the cost category, Wednesday, June 21st. These will be shorter than our typical hour-long webinars and focus on current requirements, best practices, and strategies to score high in each one of these categories for this year. We also will have a traditional hour-long webinar on achieving NCQA PCMH recognition utilizing APRIMA on Wednesday, June 14th. We will be sending out an invitation to each webinar a week or so before, and we always post on our LinkedIn page as a reminder. So keep your eyes peeled for that. Okay, so back to today's webinar focused on the improvement activity category as part of our MIPS and CHIPS Lunch and Learn series. At the end of the presentation, we will open up the floor for questions from you. We will answer all questions at the end, but you may type them in the question area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you are experiencing audio issues, please use the chat box to let us know so we can help resolve them. And again, questions may be entered in the question box. So without further delay, I would like to introduce our team who will be your presenters today. Myself, Bridget Peterson, and I am one of our Government Incentives Consultant. Lindsay Lanning, our Government Incentives Manager, and Kimmy Watson, also a Government Incentives Consultant. We have all been working with MIPS, PCMH, and many other quality reporting programs for years, and each have our own areas of expertise, and we are very excited to help your practice in any way we can. So let's begin with our third category for this series, Improvement Activity category. First, thank you everyone for joining us on this Wednesday afternoon for our deep dive into the Improvement Activity category. The idea is to provide a greater number of webinars that are a bit shorter and a little less content all at once to make MIPS more digestible, which was actually a request from one of you on our YouTube channel. See, we really do listen to what you all want. So this week's Lunch and Learn is on the Improvement Activity category, or the IA category. And here's a quick overview of what we will be covering today. We will review the IA basics, but also our recommendations to pass an audit and best practices for documentation. However, before we can get started, we have to share the announcement made by CMS in late May. If you are not on the CMS listserv, you may have missed that they officially announced the COVID-19 hardship for 2023. We were very unsure if they would allow this hardship again in 2023 since the public health emergency ends this year, but it looks like they have moved forward with it again. Now, I'm hoping I don't see our numbers just plummet off the call right now, because while yes, this would allow you not to report in 2023 and not receive a penalty, it also allows you to report only 2 categories and exclude from cost for a full score, which is huge. This means we get to go into submission picking either PI or quality and knowing exactly what our score will be when we submit. We will not have these flexibilities in future years, and there are Medicare reimbursement cuts going into effect. So our recommendation is to participate and try to offset these cuts by earning a high score. So as mentioned, we advise choosing either PI or quality as your first category to report on. However, the second category is a no-brainer. We always encourage our practices to report on the Improvement Activity category. This will be the easiest route to go, and as Kimmy will review, there are over 100 activities to choose from. Also, since it is a yes or no attestation, there isn't any data that needs to be submitted. Now, yes, there is still documentation that CMS suggests that you retain in case of an audit, but do not worry, we will review this in today's webinar. You can apply for the hardship in your QPP portal just as previous years, but do not forget, if you apply for the hardship, any data you submit or that is submitted on your behalf will override reweighting for that performance category, and the category will be scored. Okay, so back to today's presentation. This is the third portion of our Lunch and Learn series. Last webinar, we covered the promoting interoperability category. Now, we did include a quick overview of MIPS in this one, but if you need a more in-depth review, we did a deeper dive into MIPS on the first webinar in our MIPS and CHIPS series on the quality category. You can review this on our YouTube channel, or we can send you the link. Now, the Merit-Based Incentive Payment System, or MIPS track, is what we are talking about today. It was developed to improve patient health outcomes by tying payments to quality and cost-efficient care, with the intention to increase the use of healthcare information and reduce the cost of care. And believe me, we know MIPS sometimes gets a bad rap, that it's just another set of requirements and it's more clicks or burdensome workflows. And I hear you. But at its core, this program does work to improve patient care and outcomes. Because frankly, if you are following the workflows, you are likely performing more screenings and taking the extra steps to provide education, follow-up plans, or necessary referrals. And you're documenting it, so it can be shared with other providers and practices. On the administrative side, this program consolidated all the legacy programs that we used to have to report into one. So we used to have PQRS, value-based modifier, and meaningful use. And now we just have MIPS, which each one of those legacy programs aligns with the category under the current program. So under MIPS, you are required to submit data on 4 different categories, 3 of which I already mentioned: quality, then promoting interoperability and improvement activities, and lastly, cost. So the quality category is basically the old PQRS program. This category is going to consist of quality measures like documentation of current meds, blood pressure, tobacco cessation, depression screening, diabetes eye exam, etc. The PI category is the old meaningful use program, and it contains measures like your e-prescribing and patient portal access. And then we have improvement activity category. This is actually the only category under MIPS that did not stem from a legacy program and is completely new. And then finally, cost, which is the old value-based modifier program that measures spending and utilization for practices. So your performance across the MIPS category, each with specific weights, which you can see on the screen, will result in a MIPS final score of 0 to 100 points. Your MIPS final score will determine whether you receive a negative, neutral, or positive MIPS payment adjustment. Your MIPS payment adjustment is based on your performance during the 2023 performance year and is applied to payments for your Medicare Part B covered professional services beginning on January 1st of 2025. Now, not everyone has to report under MIPS. If you are new to Medicare, you get a year before you have to start reporting. You also have to be an eligible clinician type and be what's called the low volume threshold. You have to be over it, which we will look at next. And lastly, if you are participating in an advanced APM, which is like an advanced payment model, like an ACO, and you see a certain number of patients through it, you may also be exempt from MIPS. So if you're not one of the clinician types listed on this slide, you're excluded from reporting under MIPS and you will not be penalized. But if you are clinician type listed, or you have these clinician types in your practice, you may have to report for them. It just depends if they are over the low volume threshold. And this list has grown year after year. CMS just keeps adding to it. So if you're not on the list here currently, do not be surprised if in the next few years you may be. If you are an eligible clinician type, then you need to determine if you are over the low volume threshold. The low volume threshold is the volume of covered professional services Medicare patients, and associated charges a clinician or group must exceed in order to be MIPS eligible. You must participate in MIPS unless you are exempt if, in both 12-month segments of the MIPS determination period, you are billing more than $90,000 for Medicare Part B covered professional services and see more than 200 Medicare Part B patients and provide more than 200 covered professional services to Medicare Part B patients. I do want to point out that these thresholds are the same for both at the individual NPI level and the group level. So if you exceed all three low volume threshold criteria as an individual, you are eligible for MIPS and are required to participate and report MIPS data. If your practice exceeds all three low volume threshold criteria as a group, the practice is eligible for MIPS and can choose whether or not to participate as a group. So notice, individual, you are required, but to report as a group, optional. If you or your group exceeds one or two of these criteria, but not all three during one of the 12-month segments, you are not required to report, but do have the option to opt in to participate in MIPS if you would like. Some people might be thinking, are you crazy? There's no chance I would choose to do this if I didn't have to. But we actually assist a large amount of opt-in clinicians because they're already doing the required documentation and workflows, and they want the extra incentive money to help offset Medicare fee-for-service reimbursement cuts. So it is something to consider, even if you find your providers are not actually required to report. And even more of a reason to this year. With the hardship, you can take cost out of the equation, which is the only score we cannot calculate before submission. The good news is there is a simple way to check if you are eligible and over that threshold. It is what's called the QPP NPI lookup tool, and it's what we use when we assist clients with MIPS reporting. This is found on the Quality Payment Program website, which is the most helpful and informative website CMS has ever created. They really got it right with this one. I can't stress enough, not only does this website have the NPI lookup tool, but so much more. Now, when you search an NPI, it will come back and show you if a clinician is included or exempt, and their clinician details listing provider types and associated TINs, and finally the practice details. The practice details section is where we find the information on if this clinician has any associated special statuses. Now, you know what's required to report under MIPS, so let's deep dive into the IA category itself. And to get us started, I will be turning it over to Lindsay. Lindsay, it's all yours.
Awesome. Thank you so much, Bridget. So, as we reviewed before, IA is the only new category in our MIPS. And I know you all can't see me right now, but I did put air quotes around new. It was the only category that didn't stem from one of the legacy programs we were used to reporting on. And a lot of people wondered, what's the point? What does this category accomplish? So the intention of improvement activities is to actually improve clinical practice, care delivery, and of course, patient outcomes. It just takes a more abstract approach than what we're used to by focusing not on the numbers, but on the actual actions your practice takes or initiatives you're taking part in. So it's going to focus on expanded practice access, population management, care coordination, patient safety and practice assessment, achieving health equity, even emergency preparedness and response, and integrated behavioral and mental health. So each activity in the inventory provided by CMS is going to fall into one of these areas or categories. It's really, like you said, how they sort them or how they categorize each activity. And again, I know Bridget mentioned that IA is always our go-to choice for reporting when we can pick 2 out of the 4 categories. And it's because there is no reason you should not earn 100% in this category. And here's how you do it. So traditionally, IA is worth 15% of your total score. It is the lowest weighted category. Now, if there are any category reweightings going on, maybe for PI, or if you did submit the COVID-19 hardship, that EUC, this may change, but in general, it stays at 15%. The reporting period is actually the same as PI, so it's any continuous 90 days during the calendar year. But don't worry, you don't actually have to align it with your PI reporting period. You can choose to, but you can actually pick a different 90 days to attest to activities than when you're reporting and tracking for PI. And we have practices who prefer it both ways. Some practices just want to get both done and out of the way as soon as possible. And then we have other practices who prefer to focus on PI for a bit and then transition and focus on collecting documentation, screenshots, etc. for IA in a different time period of the year. There are over 100 activities to choose from, and you really just have to attest yes when you go to submit. And each activity is assigned a weight, either medium or heavy, and that's going to dictate the point value you earn for it. So the score you're trying to earn is 40 points for a perfect score in this category. So let's go ahead and break this down a bit. A medium weighted activity is going to be worth 10 points. And a high weighted activity is going to be worth 20 points. So this means, obviously, you need to report a combination of activities to earn that 40 points, that total score for 100%. What does this look like? Well, this could mean you report either 4 medium weighted activities, you could report 2 medium weighted activities and 1 high weighted activity, or you could just report 2 high weighted activities. If you choose not to attest to any activities or less than any of the combinations that we're seeing on the screen now, you're going to receive either 0 points for this category or lower than a perfect score. So I would say it's pretty straightforward, especially compared to the other categories we've looked at so far. There's no benchmarks to compare this to. There's no performance rates, and then multiplying by measure values. It's just simply reporting enough activities and saying, yes, we do these to earn the full 40 points. Now, of course, in true CMS fashion, there are exceptions to this traditional IA scoring. And this comes into play if you identify as any of these special statuses listed on the screen. I know Bridget mentioned in the QPP NPI lookup tool that, when you look up an NPI, special statuses will be listed. So, important when you look up your providers, your clinician details, that you make note of this because they do matter in this category. So if you're a PCMH or you're in a MIPS APM, you are all set. You get automatic full credit. And we'll expand on both of these here in the next few slides. Now, if you're a small practice, this means you're under 15 clinicians in your tax ID, or you're considered non-patient facing or located in a rural or health professional shortage area, you get a break. You only basically have to report on half of what's actually required under traditional IA reporting to earn the 100%. So what does that mean? Essentially, if you're one of these special statuses listed, you only have to report 1 high weighted activity or 2 medium weighted activities for a full score. Let's start with PCMH with that, the 2 automatic credit listings that we had there. There are some details we wanted to share in order to qualify as a PCMH to actually earn that automatic 100% in this category. So first is any organization that has multiple practice locations under the same tax ID. If you do have that, at least 50% of your locations have to be recognized or a certified patient-centered medical home or a comparable specialty practice to attest to this. So as we know, PCMH recognition is based on a geographic address. So again, if you have 4 locations total under your tax ID, at least 2 of them do need to be PCMH recognized to actually claim this automatic credit. If you only have 1 site, that's not going to fly. You need to report improvement activities totally. Also, CMS qualifies being a PCMH is if you're actually recognized for 90 continuous days in the year. Also, your practice has to either receive recognition from an organization that is nationally recognized. You have to be, your other option is to be in a Medicaid medical home or medical home model. Or they also offer that specialty practice designation if you've received that recognition through a program, again, that's nationally recognized. And then same thing, or if you have any other sort of recognition from another certifying body, think Joint Commission, URAC, that have a certified large number of medical organizations that, again, meet those national guidelines. So I know we assist a large number of NCQA, specifically PCMH recognized practices, and they automatically qualify for this 100%. Now, don't forget, I want to make this very clear. You do need to attest you are a PCMH in the IA category when you go to submit, so CMS knows. I know we're saying automatic here, but don't forget to actually select PCMH as your improvement activity, or they won't know, and you will get a 0 for this category. But as long as you're recognized and you select it, you are all done with one of 4 categories under MIPS. So that's a big win. Woohoo. Now, the other option to earn an automatic 100% is if you are in a MIPS APM and you're reporting via the APP, which stands for the APM performance pathway. This is an important distinction I want to make. So if you're an eligible clinician identified as participating in an APM or a MIPS APM, you're automatically going to receive 20 points out of 40 possible, so half credit for the IA category under traditional MIPS. Now, if you're an eligible clinician who's in a MIPS APM, you're going to receive full credit if you're reporting under the APP. So if you're in an APM or a MIPS APM and you're still reporting traditional MIPS, you only get half credit. You still need to report 1 to 2 activities for full credit. But if you're reporting through this relatively new APP or this APM pathway, you're all set. Now, we aren't going to get into the details of the APM pathway on this webinar, but basically, instead of choosing your quality measures, what the difference is with this APM pathway, you have to report on a designated set of measures that are outlined by CMS in this pathway. If you're still selecting whatever measures you want to report on, that's going to mean traditional MIPS for you. We did list the 2023 MIPS APMs recognized by CMS on the slide. So if you are in any one of these, you should in some way, shape, or form have to report on less or nothing in IA. So again, if you aren't sure which pathway you're using to report, either traditional or APP, number 1, let our team help you because we're really good at it. But number 2, you can always report 1 to 2 improvement activities to be safe. Now, if you report via QPP and you log into that portal and that's how you submit your data to CMS, it should show you what you're required to report on that portal, or it'll show you if you already have full credit, which will also help and be a great indicator as well. Okay, besides those few anomalies, those are really the basic category requirements. Now let's look at what changed in 2023 from last year for this category. So first, CMS did add 4 new activities focused on adopting certified health information technology for security tags for EHR data, create and implement a plan to improve care for lesbian, gay, bisexual, transgender, and queer patients, create and implement a language access plan, and then the last one is COVID-19 vaccine achievement for practice staff. So note that last one, it's for your practice staff. It's not looking at your patient vitals or patient statistics on their COVID-19 vaccination. They also modified 5 already existing activities. These modifications are actually going to be reflected in what's required to attest to it. I know Kimmy's going to go over where to find that information in the next section. So please note for these 5 listed in particular, in particular the last one, I would say, since we do have some clients reporting on this one, make sure to review the validation documentation so you see what was updated. If they added a different requirement to report on to attest yes to this, or if they added, additional requirements or things you need to meet this measure or activity. And then, of course, CMS actually did remove 6 activities. So the big ones I want to point out are first, the consultation of PDMP. As I am sure most of you know, because you were on our PI webinar, PDMP is now required. It's no longer bonus. So CMS is not allowing any double dipping to happen. And then again, the one right under it involving leadership engagement. This was a big one we saw with practices because it focused on regular meetings and utilizing meeting minutes and topics discussed to get credit for it. So please note this is not an option for 2023. If you were reporting on any of these activities in 2022 and were planning to for 2023, you just need to go back to the drawing board, review the inventory, and select some new ones. And then last but not least is this little gray banner you see on the screen. It states, note, eligible clinicians are encouraged to explore the inventory and complete different activities over time, rather than reporting the same activities year after year. I want to preface, this is not an official request by CMS, but a recommendation to report on different activities each year. As of now, there's no rule that you can't report the same activities year after year. But they added this banner, this announcement or recommendation to the 2023 inventory. It is not listed on any previous year's inventory list. Now, since we've been doing this a long time, we suspect this may change in the upcoming proposed rule that's typically released every July or August timeframe. So prepare yourselves. I doubt it will be this year, but you never know. But you may have to change activities or be capped on how many years consecutively you can report on the same activities in upcoming years. So again, just a heads up from our team to you, this is not official, but if you haven't reviewed the inventory and you've been reporting the same activities since the start of MIPS, you may want to go ahead and peruse this list again and start picking out some additional activities that may apply to you. But that is all I have for you today. I'm going to turn it over to Kimmy to review how to report, but mostly, most importantly, and really my favorite part, how to prepare for an audit for this category. So Kimmy, it is all yours.
Thank you for that insightful overview, Lindsay. Now that we know what we can report and some of the activities available, you may be asking yourselves, how do I know which activity will work for my practice? Well, first, you're going to want to consider your practice populations, your provider documentation that happens day to day, even your overall practice goals. You should select activities that are really the most meaningful to your practice and support the needs of your patients. And this will be by improving patient engagement, care coordination, patient safety, health equity, and other areas in patient care. The goal here should be to find an activity that not only aligns with the scope of your practice, but also one that aligns with any initiatives set for the remainder of the year. There are so many measures to choose from. Some improvement activities even align with the electronic clinical quality measures we can capture within the EHR, as well as the promoting interoperability measures. If your practice is capturing the screening for future fall risk measure, you can consider utilizing the implementation of fall screening and assessment programs improvement activity. Or for the closing the referral loop measure, consider the implementation of use of specialist reports back to the referring clinician or group to close the referral loop. And if your practice is utilizing a patient portal, consider the engagement of patients through implementation of improvements in patient portal activity. And if your practice is up to date in health information exchange by using a bidirectional interface, you can consider using the activity that's the primary care physician and behavioral health bilateral electronic exchange of information for shared patients. These are just a few that align with ECQMs and measures within the PI category. If those measures don't seem like a fit, we can review some of the most common improvement activities our clients report as well. The most common improvement activities our clients choose to report on are the provide 24/7 access to MIPS eligible clinicians or groups who have real-time access to the patient's medical record, the use of telehealth services that expand practice access, collection and use of patient experience and satisfaction data on access, implementation of use and specialist reports, again, that's back to the closing the referral loop, engagement of patients through the implementation of improvements in the patient portal. These activities are some of the simpler ones to report on, but before we submit them, you'll want to make sure your selections are able to get you the maximum points for this category. So whichever combination of medium activities or high weighted activity you choose, they'll add up to a total of 40 points, right? Lindsay went over that with us together. So your improvement activities performance category score is then multiplied by the 15% improvement activity performance category weight. The overall improvement activities performance category score is added to the other performance category scores to determine your final MIPS score. You can't earn more than 40 points in this performance category, regardless of the number of activities you plan to submit, but please note that the submission platforms may allow you to attest to more than 40 points worth of activities. If you do attest to more than 40 points worth of activities, you are responsible for compiling and maintaining documentation for all activities to which you attest, even though these additional activities won't increase your score. So, let's say you're a large practice that only selects one medium weighted activity to attest. To calculate your improvement activity score, you would divide the 10 points for that medium weight of the activity selected by the total 40 points available for the improvement activities. And then you would want to multiply the improvement activity category weight, which is 15, to get your final improvement activity points that contribute to your MIPS program score. Not too bad. If you're a small practice, meaning your practice has fewer than 15 providers, you don't have to report PI, and you'll notice the weights for the IA category changes to 30%, and PI will be reweighted to 0. So to calculate your IA category score, you would divide the 20 points for the medium weight activity that's selected by the total 40 points that's available, and then multiply by the IA category weight of 30 to get your final IA points that contribute to your MIPS program score. It's really important to be familiar with how the categories are calculated, so when it comes time for submission, your scores can align with your expectations. No one wants to be surprised. So now that you know how to calculate your score, the QPP does the QPP rely on your math to tally your performance? Fortunately for us MIPS math non-maticians, no. At the time of submission, you'll simply select which activities your practice has chosen. While you don't have to submit any supporting documentation when you attest to completing an improvement activity, you must keep documentation of the efforts you or your group or APM entity undertook to meet the improvement activity for 6 years subsequent to submission. And that brings us to our next section. 6 years is a very long time to keep data. However, we want to make sure in the case of an audit, your practice has all the information and documentation in place to back up all your hard work and dedication to your patients. Whether you keep your supporting documentation in a physical binder, digital folder, you'll want to ensure that your care teams know where the information is kept. This is in case of any staff changes or turnover. I cannot tell you how many times I've spoken to new clinical team members, office managers, and physicians who have no idea where their documentation is located. So to avoid any potential headaches, take the time to discuss with your team what methods and locations would work best for your practice. One thing that's often overlooked, though, is when retaining the documentation necessary for your audit preparedness, is that you respect the HIPAA minimum necessary standard. So you'll want to be sure to redact or blur any PHI or protected health information if/when the auditor requests specific records. If the piece of information is not required to fulfill the purpose, keep it out. It's not needed. So how you set up your binder or electronic folder will depend on if you report it as a group or an individual. If you report it individually, you need everything we listed in the previous section for each provider or clinician you reported for. We recommend separate folders for each clinician reported for electronically, and maybe sort by tabs or file folder if you have a physical copy. These are some things like the EHR purchase info or the security risk analysis that apply practice-wide and can be kept in one communal place, but category data and documentation will need to be separate. If you report it as a group, you can save down the documentation at the TIN level. This is much less work because you should only have about one set of documentation for the entire practice that year. Again, very important that you have those lists included of which providers and NPIs that were included for your group that reporting year. Now, for This category in particular, it's really hard to give examples like you would for promoting interoperability because everyone will be different. My recommendations are to immediately download the data validation file for your improvement activity. Select activities that your practice is already doing and doing well, and then follow the suggested documentation for the activity to dictate what you save down as supporting documentation. Some examples of what clients have saved in the past are screenshots, performance reports, policies and procedures, AUC examples, portal documentation, meeting minutes, training materials, and other agreements. Now, if we look at the activity I pulled on the screen that would apply to most practices on the call is engagement of patients through implementation of improvements in patient portal. The validation documentation CMS suggests is screenshots of the portal. Typically, we do screenshots of functionality from the patient perspective on how they can access education. We also try to find portal messages from patients that the practice responded to show bidirectional communication. And then we also have the certified report to show how many patients have access to the portal. Again, this is just an idea of what we try to put in place based off of CMS's advice, but this is what an auditor will look at as well, so please do not ignore this file. Something else to note that was new in 2020 is that qualified registries are required by CMS to validate the documentation that practices have on file to support the submission of their selected improvement activities. What this means is that you may have to submit documentation prior to submission via the registry, and you will not have to submit the upload documentation if submitting through the QPP. This isn't technically a new requirement since you should always have documentation to support your improvement activities in case of an audit. However, 2020 was the first year you actually had to submit that evidence in order to be able to submit via a registry. Now, if you choose not to submit via certified registry, you can submit manually via the CMS QPP website, and you would not be required to upload the documentation. Still keep in mind, if CMS knows registries require this, we have a very strong feeling the odds of you getting selected for an audit are a lot less because you had to go through this process already. And lastly, our own personal recommendation for saving audit documentation is to create a template. Then your documentation follows the same pattern, not just a bunch of screenshots saved to a folder that in 6 years, if you aren't at the practice anymore, or even if you are trying to piece together what it all means and include the validation documentation since this changes year over year. Creating a Word document that lives with your admin documentation, whether printed or digital, will help your practice stay efficient and organized, allowing you to ace an audit if your practice does get selected in the future. With MIPS, there's so many different facets and updates to manage. So if you're feeling like this was an overwhelming amount of information, please don't hesitate to reach out to our team. We are here to make MIPS manageable.
Absolutely. With all this information and of course talk of audits, it can seem a bit daunting, even for the easiest performance category, as we mentioned. So we understand this is our full-time job. I'm sure for most of you on the line, it's not. And the good news is you don't have to do MIPS alone. Real quick spiel here, your DAS, GI, or government incentives team is here to help. We've got all kinds of assistance packages to best fit your needs. We can do ongoing, as needed, whatever your practice needs. The ongoing support is definitely our most popular. It's really all-encompassing MIPS support from start to finish. We assist with data analysis, report retrieval, PI measure training, quality measure training, selecting improvement activities and helping you save down that documentation for an audit. Performance analysis with specific action items each month or every few weeks, however often you want to meet to improve your score over time. We help you with submission, audit guidance, etc. So we're even willing to try and teach your practice resource if you have one, the program and its requirements, with the goal of you to bring it in-house in the future. Again, we really just want to help make this program easier, and definitely avoid a penalty, but also try and get you a piece of the pie here to offset these Medicare cuts that have been put into place. So that is it. We have made it as promised. These are a bit shorter. So if you are asking yourself what your next steps should be, We definitely recommend to visit our website if you want to learn more about us. Continue to sign up for our webinars. We do have one more left in our series based on the cost category. And then we do offer PCMH webinars that are EHR specific. We're going to do a Prima next, but then we'll have a next gen one shortly after as well. And of course, if this did seem overwhelming, you want another set of eyes looking at your data or really taking this over for your practice, whatever you prefer, consider working with our team. We can offer that guidance and assistance in any form. You would be working directly with myself, Kimmy, or Bridget. It's us three. So just reach out to your DAS account manager if you're a current client, or if you don't have one yet, you can email us directly. Here's our contact information, and of course, Kimmy's beautiful face. So don't hesitate to reach out. I know we wanted to open the floor up to questions from you on the IA category. So if you do have a question, feel free to type them in the questions panel now. And then Bridget, let me know. I know you may be answering some of them in the chat throughout the presentation after you were done presenting, but if there weren't any answered or any we want to read aloud, feel free to start dishing them out.
Yes, we actually have a few great questions that I did want to leave at the end so everyone can hear. Our first question is regarding the slide that you had mentioned where CMS is encouraging clinicians to select different improvement activity categories each year. Lindsay, can you review that again, that information?
Yeah, absolutely. So just want to throw out there, it is not, that is a presumptive basically prediction that we're making, our team is making. There is nothing official right now stating that you have to report different improvement activities year after year. I would just, we've been doing this a few years. We've been working with CMS for a while. They added that banner to the 2023 IA inventory, that validation document that we're suggesting you all download that goes over the suggested documentation. They added that banner new this year. So we all know CMS comes out typically with a proposed rule of changes for this program every July or August timeframe. There may be an update to this category coming in future years that we will likely have to change improvement activities year after year. So again, nothing official right now. This would be more of something that we're guessing at and trying to let you all to either be on the lookout, in the next few months to see if that is announced, and two, make sure maybe you want to revisit that inventory list. I know we definitely have some clients who've been, reporting on the same ones because there wasn't a rule in place since the inception of the program. So you might just want to go ahead and revisit the inventory, look through it, see if you can identify any ones you could report on if needed. But again, there is no official need to change your activities year over year right now. We just predict that may be coming in the next few years based on that recommendation that was added to their inventory list.
Great, thank you. All right, so the next question is, can I change my IA at some point in the year if I decide the one I previously selected no longer applies? And I can go ahead and take this one because this is a great question. And yes, you can always select a new IA, but remember that the IA category requires a 90-day reporting period. So as long as you have at least that 90 days to report, the only other suggestion is to make sure you have that documentation you need for that time frame. Basically, the idea is not to reinvent the wheel, but get credit for something your practice is currently doing or working on. Lindsay, anything else you'd like to add to that?
No, that's it. I was going to say we have practices all the time who, whether there's a change in the practice or, for any reason they want to pivot activities just based on documentation. I know we had practices previously who were using PDMP and maybe they actually didn't, prescribe a narcotic they had to look up in that 90 days. So we had to change. So the beauty of it, we always encourage for PI and IA really, if it is a 90-day reporting period, to try and get it out of the way at the beginning of the year, or at least don't wait for the fourth quarter. So you can, go ahead and change activities. The main thing to consider is that most documentation for the improvement activity category will likely require some sort of screenshot, and that needs to be dated within your 90 days. So if you change activities, and it's June 7th right now, and you want to change your activity for Q1, you're likely not going to be able to do that. If you change activities, you need to go ahead and report for the 90 days that you're currently in.
Great, thank you. Okay, if I cannot locate my improvement activity documentation from last year or previous years before that, what should we do? Kimmy, I'm going to send this to you.
Yeah, I can take that. Thanks, Bridget. So if you can't locate your improvement activity documentation, but you do know what activity your practice had selected, CMS does have the validation documentation available on their website, so sooner rather than later, I would recommend that you go back and review the validation documentation that is required. And then if your EHR allows you to go back to review those examples, you can capture it there as well. But you'll want to make sure that you are able to review what was submitted to the QPP at the time of submission for that specific year, and then you can locate that documentation within your EHR if available. And then if you can't find that documentation, definitely reach out to our team so we can find some more additional information for you, and maybe even, you know, work a little bit of magic and see if we can find it for you. But definitely do a deep dive into your system and see if you can find it, because in the case of an audit, you don't want to wait to the last minute. The worst thing is to need it and not have it. So definitely want to locate that documentation as soon as possible.
Great, thank you, Kimmy. Okay, one final question. We typically submit more than what's required in IA. Should we not be? Lindsay, I'll
Cool.
give that to you. Good
I was
question.
going to say I can take this one. And I remember the first year of the program, you know, not understanding how to use the QPP portal. We had some clients who, you know, came to us and said, "Oh, we just selected all the activities for submission." So, what I want to preface is, you know, we definitely have some practices who prefer to submit, you know, maybe 5 medium weighted activities and just the required 4. The only thing I caution, and I know Kimmy mentioned on one of her slides, is that whatever improvement activity you submit, you're going to have to show documentation for in case of an audit. So, you know, I know there's a thought process behind it. Well, if I submit 5 and I can only prove 4, you know, they'll still pass me. And CMS has clarified, you know, that's not the thinking they have. They are going to hold you accountable for every single activity you attested yes to, and you will have to provide that documentation to pass an audit. So, you know, our recommendation, you know, especially in this category, is to really try and focus on just the, you know, 1 to, I guess, 4, up to 4 activities that you really have to report on to meet 100%. You know, I know Kimmy mentioned you can't go over 40, you're not going to get any bonus points here. It's just going to actually require more documentation for you to keep on hand in case of an audit. So that's kind of our perspective or take on it.
Great, and I think that's it, Lindsay. Kimmy,
Awesome.
anything else? Awesome. Thank you, guys.
Great, perfect. Well, thank you all so much. Like I said, you've got our contact information up on the slide. We will be sending out a link to the recording and a copy of the slide deck here in the next few days. If you do have any questions or you want to learn more about how we can help, you know, feel free to reply to that email or reach out to that email on the screen. Or, of course, if you are a current client, your account manager. I think that's all we have for you today. So thank you all so much for joining us.